All right, we'll get started. Good afternoon, guys. We are going to do a couple different things today. The first thing we're going to do is finish up Chapter 5 where we were already working on. We'll knock out Chapter 5. Then we're going to just talk about an activity. I got a video that I would like to show you, and we may get into Chapter 6 a little bit. We'll just see how the time goes on that. But the first thing is I will tell you I did not finish grading your case study things that you turned in to me. I'm on the contact tracing squad for the university, so I ended up, some of the time I was planning on grading, I was making phone calls and putting stuff in the database. So I try to get things back as quick as I can, but we have plenty of time to do that. Like I said, we're probably going to, what I'm going to do when I get those graded, I want to grade them pretty thorough where I can, when I give them back, you can know exactly what you were, what to look at to correct it when we do it again, because we'll do it at least one more time, just a different case study, basically, the same type thing. Like I said, and that's just building primarily for me wanting to see goals and objectives that are therapeutic in nature, number one, recreation and leisure based and written properly. That's one of the things that I really, really want you guys leaving this class with, that and understanding that how we provide the activities that we're giving to our patients matters. How do we communicate with them? How do we, what's the reason of building rapport with our patients? How do we show them that we're listening? How do we listen with empathy? Things like that you can use in the field. And even if you're not in recreation therapy, it's going to be things that will be useful for you as far as dealing with people in your field. So let me share screen here and go to the PowerPoint. Okay, we talked about Teach Back, and we know that we can use it as a provider to show someone that we understand what they're telling us. You're kind of paraphrase and tell them what they just said to you to make them understand that you were listening, and vice versa. You can have the person that you're trying to instruct or talk to about something come back to you with what you said to show that they gathered where you were coming from. And that's just a rehash. We covered that stuff already. We also, I think we talked a little bit about health literacy and cultural competence. And what this has to do with is, a lot of people can't make decisions. Like I said, at the NMRC, that was a situation where my clients, they had developmental disabilities. They couldn't make appropriate decisions regarding their care. And we have to realize that some of the people that we are working for and working with aren't able to make those decisions. So we have to, follow the code of ethics that we talked about earlier in the semester and try to stick to that and choose things that are in the best interest and will show the most benefit to the patients that we're working with. So these things we already had here. You can use multiple forms of communication to help people understand. Now, because someone is, say, developmentally delayed, they're 45 years old, but they are on they're 6 years old on the mental level. Do you need to get down and talk to them like this and talk real slow? And what's that going to do? I mean, yes, you might want to slow down what you're saying a little bit to help them understand what you're trying to get across, but don't be condescending and that's not going to make them, they're going to catch on to that basically. My 7-year-old boy would pick up on that if someone was talking to him in that way. Hey, this person thinks I'm stupid. That would be the way he would teach back to me what's going on. So don't do that. But, maybe slow down a little bit on what you're saying. Try not to use jargon or any, terms that they're not going to understand. It's like I said, instead of saying to someone in that situation, hey, we've got to get you to a 90-degree knee bend, we got to say, what we're going to do is we're going to work to get you to where you can bend your leg like this, something they can see, something that's concrete, and that they don't have to understand even what 90 degrees is. Okay? Be specific. You can use analogies to help people understand what you're talking about. Bring it into something that they deal with on a daily basis to help them comprehend what you're saying. Help them ask questions or encourage them to ask questions. Check multiple times to see if they understand what you're saying and where, what you're talking about. Do you understand when I say we're going to work on this? Do you know what I'm talking about? And that's, again, not being in a condescending way, but just making sure that they feel like they can ask questions. And you can confirm that comprehension using the teach back method we talked about. All right, healthcare mnemonics. These are just kind of fun ways of helping you to understand some good steps to better communication. You got to understand, communication is paramount to you being successful when you're working with patients. If you're unable to communicate with them effectively, then obviously, everything you're doing is not going to be as effective as it could be, So you got to make sure. That's why we're spending the time that we're spending on this stuff about communication. It's not directly, this is how you run a therapeutic recreation activity. But if you can't communicate, you can't run a therapeutic recreation activity, because you won't be able to get the people to understand what you're doing or to engage with what you're trying to get them to engage with. So one of these mnemonics that we're talking about, it's 4 E's. Engagement, you want to have your people engaged. Empathy, you want them to understand that you feel where they're coming from. You're empathetic to anything that, because if you're working with someone, generally they've got some sort of issue that, issues, kind of a ugly word to put it, but they've got something going on that we're trying to help. Whether it is, depression, whether it's anxiety, whether it's a physical ailment, whether it's, wanting to be more social, things, whatever that is, they've got something going on, and we need to be empathetic to that cause that we're working on. Education, that goes back to what we were talking about on the previous slide. You want to make sure that they understand, and that may include us giving a little bit of education in our communication and enlistment. That's kind of getting them to buy into what we're doing. The next one is bathe. When you're trying to communicate with someone, there's some things that you need to kind of take into effect. And some of these things are things that you can just see. What is someone's background? The way that someone acts or reacts a lot of times has a lot to do with their background. What does let's say a soldier who's been to Iraq on 4 deployments do if they hear a gunshot? Probably, it's going to send them right back there. That's their background. You need to know. We probably won't be working with that person, but I'm just saying, you need to know the background to understand. That helps us to be empathetic, because we understand, because of their background, this is why they act this way. If someone has been sexually abused in the past, something like that, that's probably going to be in their paperwork from when they come into the facility. Those are things that you need to No, because, you know, if they're extremely shy to all males, then maybe it won't be such a, you know, why is she like that for you? You know, you kind of would understand that there's a reason for it. So background plays an important role. Affect, you're going to look and see. You can look at somebody's face generally and tell what sort of affect they have. You know, are they flat? Do they always have like a flat demeanor, just looking at you blank? Some people have an affect that's happy and smiling and glowing, you know, even when they're not feeling that way. They can put, but most people you can kind of read by their affect. That's kind of like their mood that you can see on them by looking at someone and how they're acting in general, their affect, their mood. Troubles, a lot of times you need to know what kind of troubles they're having. And that goes into the next ones. How are they handling current situations? And then we need to make sure that we are giving empathic responses, you know, where we're showing empathy for the patients, the clients that are having troubles, that may be having something due to their background that is bothering them. The next one on here, grip. You want to get a measure of the patient's symptoms and complaints, basically, and that's going to happen in the assessment phase. Back to the API thing, everything goes to API. You're going to get the measure of their symptoms and complaints. That's where you find out where their issues are that we're going to work with. You're going to respond, that's the R, to refocus the patient's understanding of complaints. You're showing them that there's, this is how we are going to address this. You know, you see this as something that you've dealt with for 10 years. Hey, we're going to try to find a way to get past it. So that's where you're trying to respond to the reason they're there. You're giving them a response to it. By identifying resources and solutions, and then promote coping. See, coping is something that they talked about a lot when I was doing some work at the drug and alcohol abuse facility. These people, you know, what are a lot of people doing when they drink or take drugs? Trying to, you know, maybe numb themselves, forget about something that's going on, trying to take themselves into another place other than where they really are, you know. So that's their coping mechanism or their coping skills when they come in to that setting. And what we have to do is we want to promote coping in other ways, obviously. You know, we talk about, okay, you know, they would talk with them about what is your trigger? You know, what causes you to want to drink the most? Is it who you're around? Is it stress? Is it, you know, and then we find some things through the process and the time that we're working with them that they enjoy doing, and we try to give them some more appropriate coping options other than that. That's the place I think of the most when I think of coping skills and replacement behaviors. Now, we did that same thing, you know, at the NMRC. I had patients that had certain situations that would set them off and make them misbehave, and a lot of people wouldn't understand why they were misbehaving, you know. And that's where you have to go through some of these things that we're talking about, where you have to look at background. You have to understand that this client has been diagnosed with autism and they are very strict to a schedule. They may not even speak, but they know that at 2 o'clock, they are supposed to go to music class. And if it's 2:01 and you're still in the classroom, they might start flipping tables. Sounds kind of crazy, but it's true. And if you don't know the client, know the background, then, you know, that's a case where you have to find coping situations where you teach them when you feel upset, rather than flipping the tables and, you know, slapping your classmates, we're going to make this your corner over here, and we're going to put, three of your favorite things, and I want you to go over here, and you're not going to, you can have, while we're getting the class ready, we're still going to go to music. I promise. We're just running them a couple minutes late. You just go over there with your things, and then we'll go. You're giving them a coping mechanism. So it happens in a lot of different settings. There's some tools that are used. This would be more so that we would probably cover this more so in the 388 class after this one, where we talk about assessments, obviously, because since this is a communication assessment tool, it is a way that patients, you can allow patients to evaluate other residents and physicians' communications skills. It's rated on a 5-point scale. It's basically a 15-item survey to test patients' perception of patient-centered communication during outpatient care. Are they getting the type of communication that we're supposed to be giving them? That's kind of what it's looking at. You're finding out how they feel about the way they're being communicated with. And that's important. It'll tell you a lot about how you can improve what you're doing, not just you, but as a team as a whole. There's 4 categories: problem solving, respect, lack of hostility, and nonverbal immediacy. Are you coming to them without an undue, without a lag in time, basically, is what we're talking about here. Are they being spoken with hostility? That happens. I know you guys have seen like these nursing home videos and like daycare videos that make you sick. At least I have, where the patients are being mistreated because, and you know who the ones that's happening to the most, especially in these like nursing home settings? The ones that are farther along in the progression. They're probably not verbal for the most part. If they do, you may talk a lot of gibberish. People don't really believe them when they say things. They're out there with what they say. So the workers feel like that they can do whatever, because even if they tell it, all they're going to do is just say, no, that didn't happen. Tom's crazy. That's what happens. So some more about communication techniques and strategies. If you're going to communicate well, it takes considerable skill, practice over many occurrences, and repeated feedback. That's why at the end of the semesters, y'all don't think much about this, but believe me, it matters to me as an instructor. These evaluations that you're asked to do at the end of the classes on your instructors, we don't get to see them until, like for last semester, mine just opened up like last week. All my grades have been long gone. I can't go back and change what I gave somebody because I don't like what they said. Now, of course, I want y'all to put all 5s for me. Like everything was fantastic. But that's because I try to come in here and be prepared and speak loud enough that you can hear me. And that's things that I have, I didn't come through the normal channels to be up here talking to you guys. I didn't go to school to be a teacher. I went to school and then went into the field and worked in the field for 20 years or longer. And I feel in a lot of ways, I'm glad that that's how I got here, because I've got the experiences to tell you about that I wouldn't have had I just come through academia path. That being said, you know, that top part relates directly to me. And I've been here for a couple of years now, and I can tell you, I wasn't an incredibly shy person to start with or anything, but I am much more comfortable talking about what we're talking about. Volume has gotten better. I'm more prepared for my classes as I go farther along. It's things that comes from considerable skill, practice over many occurrences. I've taught a bunch of courses now, so obviously I'm getting better. When you are doing activities, if you go into rec therapy, and the first day you go in there and you're going to do recreation therapy, activity therapy class, you're going to be excited, but you're going to be nervous. And that's good. Being nervous isn't necessarily a bad thing, you know. It shows that you care about what you're going to do. That's one thing about nerves. But you just, after you do it the first time and you see, hey, I lived through it, and they were smiling when we got done, and how are you going to feel the next time? A little more confident? You're going to come in and be a little looser the next time, you know. Do that for a few years. Before you know it, you're not even, you know, you just go in there and do your thing. And that's from practice over many occurrences and getting feedback, whether it's, and I'm not saying you have to give them some sort of sheet for them to fill out on your performance each time. You don't even have to ask them, what did y'all think about that? You don't have to do that. You can tell by how people look when they're leaving your activity a lot of times and during that activity, whether or not what you provided that day was what they needed, was as good as you could have done. So you can get feedback without someone actually feeding it to you. You know, sometimes it's visual feedback that you're going to get from seeing how people react. The therapist needs to be careful not to under-participate, which would be looking away. This is talking about just communication techniques. So jump back out of leading an activity. Now, obviously, this is if I'm talking to somebody and I want to make that connection where they feel like they can trust me and they know that I'm looking out for their best interest. If you're going to give them that impression, and it needs to be true, don't under participate. When you're talking with them, don't be looking away. Don't be checking your email while they're telling you something real important. Appear stiff, like you're just, there's different, we all talked about body language and how you can see, and there's people that actually, like forensically examine body language. They can tell when somebody's lying when they're in a deposition room and you've got, detectives or police are questioning, examining someone. There's people that can look and say, you see when he just leaned back like that? That tells me so-and-so. Like there's so much that can be seen from your appearance. So if you appear stiff, unapproachable, I'm standing up here. I realized a second ago when I was saying that I had my arms crossed. Of course, I'm just comfortable up here. That doesn't mean I'm closed off to you, but what does arms crossed when someone's talking to you generally mean? That they're angry or that you're kind of closed off. You don't really care, if someone's talking to you and you're sitting there and you just lean back in your chair, it is not as effective as you kind of, almost leaning forward. You are focused on them. Whole different vibe. Just a lot of different things that go into that. Also, be careful not to over-participate. Don't give them a chance to be a part of the communication. Don't over participate with excessive movements, overly loud voice, you know, cutting them off, trying to finish their sentences, things like that. Don't over participate. Share. It's a sharing situation. If, you know, communication is a two-way street, and that's, you know, cliche, but it's true. If you're doing all of it, it's not really communication, not true communication. You also don't want to distract. Frequent nervous laughter, that would be distracting. You know, if somebody's talking to you about something, especially if it's, say, something serious, and you've got, you know, doing this little nervous laugh, that would be a little unnerving to that person and make them want to just shut it down. I would. I'm trying to talk to somebody and they're doing this little nervous laugh, I'd be like, okay, I'm done. So don't do that, obviously. And changing subjects, that would be under distracting. Obviously not something good to do if we're, you know, the person you're dealing with and talking to, especially if they're talking to you about something important, you know, something that is going to play into their well-being. Now, if you're talking about fishing and you think about a time that you caught a fish somewhere and it was similar to their story, I mean, yeah, you can jump around, but in a serious conversation, communication, you don't want to change off of an important subject, put it that way. Some more communication techniques and strategies that will help you attend to the individual by watching their facial expressions and their body language. Just like what I said, you can tell when somebody, you can tell if you piss somebody off when you're talking to them. Generally, you see a change. You see a change in their face. You see a change in the way they're sitting. You know, if you get slapped, that's a good indicator that you made someone mad. That happens to me at home, not generally in practice. Active listening, you want to do that. Make sure that you involve sensing, processing, and responding to the incoming messages, which basically you are actively listening to the person that you're talking to. You're trying to not just hear the words. You want to sense what, you know, you may have to try to read between the lines a little bit if you have someone who doesn't communicate as straightforward as you would like them to. Now, don't fill in the blanks with what you just want to be there. You know what I'm saying? Don't overfill, but you want to really try to put together and process when someone's talking to you, and then respond to them to let them know that you heard what they said, that you understand what they said. Realize this next thing is kind of important, and this is something that makes a lot of people uncomfortable, and a lot of times it can be very useful, actually. The therapeutic use of silence. Sometimes when you're conversating with someone, you know, we've all heard the term and used the term awkward silence. And there's times when, you know, my wife will call me on the phone. Hey, what are you doing? And I'll say something, and, you know, I'm kind of busy working. And then I'm just sitting there like, I didn't call her, so I'm waiting on her to come on with, finally I'm like, did you need something? You know, not trying to be rude. I'm just saying, like, there's times where silence is actually awkward silence. Sometimes, especially in situations where our patients or clients may not be in the clearest of mindset, you know, think drug and alcohol rehabilitation program, think developmental disabilities who have a slower processing time to start with. This therapeutic use of silence, which is planned and allowed for, gives them time to assimilate information, for it to load in, because it may take them longer to comprehend what you're saying than it would, you know, you or I. Assimilate the information or continue more deeply in the issue at hand. So understand that silence is not necessarily always awkward and not necessarily a bad thing. Sometimes it needs to be there in communication, depending on who you're speaking with. So remember that. Self-disclosure. Don't be afraid to reveal your own reactions to the person of the group. What will that do for the group if they actually, like if you're not afraid to tell them what you're thinking and feeling? What are they going to do in turn? They'll do the same thing. They'll open up too. If they see you opening up about, what your reactions are, then somebody's probably going to come right back at you with their reaction. Because, hey, if the leader's doing it, then I can do it too because he's doing this for us. That's kind of what that one is all about. Communication focus. You want choice of responding to the content of the exchange or the feeling of the exchange. Some communication sessions or some talks, you have to realize that it may be less about content and more about the way someone is feeling. Especially, recreation therapy, that's something that I love about what we offer, that we can touch on feelings and anxiety and depression and things like that. And that's what sets us apart as a therapy in relation to, say, physical therapy and occupational therapy. We touch on the mindset of people, and that's what something that I really like. So for us, that gives us a chance to realize that communication sometimes really what we need to come out of, we may not be trying to get a lot of content. We may need to see how someone is feeling that day. We don't need a lot of details on every little single thing, but we may need to see what their affect is, what their mood is, how their day has gone, or if they are feeling bad, what got them to that point. If you can tell they're in a bad mindset, what got them there? What sort of feelings are they having because of this? So you can work on that the next time. Restatement is a lot like teach back. Repetition of the main thought or feeling expressing by the client's preceding information and neither adds or detracts from it. That's basically, that's teach back is all it is, the same thing. You're just telling them, this is what you said. You're not adding anything to it. You're not taking anything from it. You may word it a little differently, a little more simple, something like that, but you're not adding or detracting from the message. Reflection of feeling is another thing. It's paraphrased response to a feeling that is expressed by the client, verbalized or not. Where hey, sometimes you might not be right. Where you can say, so what the way I feel after our talk, I feel like you're a little down today. That's a subjective thing. You're making a decision on based the way they look, the way their voice sounds, the way they're talking, some of the things they might have said. You're paraphrasing, a feeling expressed by the client that you have seen or heard. At that point, you'll find out whether or not you're right, because if you're wrong, they're going to tell you. So just remember that. Some more, and we're almost done with this chapter. I think this is the last slide here. Summarization of feelings helps to provide meaning and continuity and can help the client move on. If you get a client to open up, if you get them to, that's where, again, during the assessment portion where you're going to have the quote interview where you're getting to meet your patient, and I talk about how important rapport is. If you build a relationship and a rapport and they see that you, when they're talking to you, that you're listening to them and you're not looking off into the distance and you're not distracted, they are going to be much more open to telling you the things that you can help them to move on from. If you don't have that relationship, they're not going to be as open. And you don't want to try to be filling in a lot of blanks if it's something that you can just build a relationship. I'm not saying we got to be best friends with everybody that we work with. That's not going to happen. They just need to know that you're on their side and that you're trying to help them and that what you're doing for them is based on, sound theory and research and experience and things that you know are going to help them. If they know those things and they trust you, then they're going to talk to you and they're going to give you the things that they need to move on from. Request for clarification. That happens when the interviewer asks the client to rephrase or reword what they said. Sometimes it may be unclear exactly what somebody means, and you may need to get some clarification. They may do the same thing for us. If I'm talking to you guys and you don't understand something, you may want me to reword it in a different way that you can understand. Probe. I'm not talking about the new COVID test. This is used when more than a yes or no answer is desired from the client. A lot of questions we can ask have that yes or no. Are you feeling happy today? Have you had a good day? Well, that's yes or no. If you want more out of it, if you want to know a how, when, where, more explanation, then you're going to have to probe with the way you are giving questions. Accent. 1 or 2 word restatements that focus on or brings attention to a preceding client response. You take the important part and kind of restate. You're accentuating the important portion. Is kind of what we're talking about here. iMessages. And this, again, we're not talking about the kind that you send from your iPhone. I'm an Android guy, by the way. Always have been. I'm not buying into the iPhone stuff. Honestly communicate the effect of the other person's behavior on you. That's you showing vulnerability and honesty with your patient, where you make statements about, I feel this way, or this is how I deal with this situation. iMessages. You tell them about yourself and how you handle different things. Ability potential response. That's going to help the client understand that they have the ability to make choices and the capability to succeed in meeting their goals. That's one of our most important roles as a recreation therapist, is to be able to pep talk them, for lack of a better word, into saying, hey, we're going to get past this. We're going to have you doing this. I set up for a little side gig for a while. I was setting up patients that were having total knee replacements. And I would go in and I would bring them the walker that they would need when they got it, the bedside commode chair that they would put over their commode where they wouldn't have to squat down so far, and a CPM unit which bends your leg back and forth. Some of y'all may have been in one. I've been in one, not fun to me. But I would always, when I was leaving, I was like, they'd be like, well, I'm just ready to get this done. I'm nervous about it now. And I would say something like, hey, when I come back in 3 weeks to get this machine, you're probably going to be push mowing the front yard. Or you're going to be doing jumping jacks when I come back in 3 weeks. I'm being over the top. They weren't going to be doing those things, but that is me saying, using this ability potential response, saying, look, you're going to be fine. You're going to be successful in coming out the other side of this thing. Confrontation. Sometimes, now confrontation sounds like a kind of a dirty word, especially if you're talking about in a therapeutic setting. Do you want confrontation? No, not really. Now, I'm not talking about getting in a fist fight with somebody, but I'm talking about sometimes people, if the patients that we're talking to, okay, again, back to the drug and alcohol rehabilitation setting. What are they best at making in there? Excuses. I promise you, they can come up with some reasons why they do it or why they can't stop. Hadn't been there. I know it's hard. I'm not discounting that for anybody. But sometimes as a therapist, as a recreation therapist, it is our role to help clients recognize discrepancy, contradictions, irrational statements that they may be making, or excuses in regard for their own behavior. So that's basically tough love. Say, look, I care about you, man, and I'm just telling you, what you're giving me right now is BS. You can stop, that's basically what it's talking about. You have to, and that's not terrible confrontation, but you're kind of calling them out on things that they're either contradicting themselves, where they told you one thing and then they didn't do it, or they're making an excuse, and you just say, look, you're just making an excuse. You have to tell them that. And if they know that you care about them, they're going to be okay with that. They might be pissed off with you when they leave that day, and you know what? That's okay. When they get home or back to their room or wherever they're going to realize, you know what? They were right. I was making an excuse. When they're sitting there in the quiet by themselves, they're going to realize, and that's a part of communication that sometimes we don't want to do, but it's important to do. So confrontation done in a proper way is very effective. Doesn't want to be our go-to move. You don't want confrontation to be your way of, you're not looking for the first time you can call somebody out on something that they told you wrong. That's not what we're talking about. But if you see brazen discrepancy, contradiction, or something that's just irrational, you may have some people that you deal with who may have, in a psychiatric type situation where it talks about here rationalization. They may be having irrational thoughts. Alzheimer's patients. Now, Alzheimer's patients, a lot of times the best way to work with them, and I'm off topic a little bit here, is it's not worth correcting them most of the time, because you just want them to be as happy as possible. They're not going to remember your correction the next day. It's not going to stick with them. I'm not trying to be rude. I'm just saying with them, it's not so much. But just be sure if somebody needs to be shown some tough love that you're able to do that. And at the end of it, when they're sitting there gritting their teeth at you and just wanting to get up and leave, remind them, hey, I'm telling you this because I care. And that carries a lot of weight. Conflict resolution. Number one thing, whether it's in rec therapy, whether it's in whatever setting, your goal is to create a win-win situation where both parties get benefit in communication strategy. You want to have communication where one person is really enjoying the conversation and the others get nothing out of it? No. You just want it to be where both people are involved, engaged, actively listening. If you're spending the time to communicate, make sure that you are doing something worthwhile. And that is it. Y'all can look back at that if you want. I'm going to stop the share on that for the moment. I'm not going to go into chapter 6 today. I don't want to get started on a whole new chapter. I believe that test 1 is going to cover chapters 1 through 7. So that gives you a little bit of an idea that we're kind of getting, we're through 5 chapters now. If you, I would read the book. I would read the chapters when you get a chance. We talk about most of it in here, but not every single thing. But I'm going to give you time to know when the test is going to be. I don't know exactly right off the top of my head right now. So just know that the next time we meet, we're going to talk about chapter 6. Okay. What else? I'm going to turn on a video that I pulled up, and it's nothing earth-shattering. It just shows some different things that people can do with therapeutic recreation. And then I've got this that I'm going to hand out during the video. And I just want to talk with you guys for a few minutes about this as an activity, because we haven't, for the last several classes, really talked about running an activity. Okay. So let me share the screen for the ones who aren't here and get to here and go here. And some y'all heard it before now. Ones of you guys that were in here. It's here is where it's at. I think this is where it comes out. See, that makes me mad because I came in here 30 minutes early today to make sure this was going to work. Now let me, that's not the good one. Therapeutic recreation. All right. I guess that's as good as it's going to get. I don't know what happened to the good speakers that were coming through the ceiling, but they have good sound in here.
Therapeutic recreation, or TREC here at Craig Hospital, is, well, it's therapeutic recreation. So what that is globally is the use of sport, recreation, leisure as a modality to help people, or at least here at Craig, to help them achieve some of their therapy goals that they have. At Craig, therapeutic recreation is part of that treatment team that we surround our patients with. So they hear and work very closely with the other disciplines, OT, PT, speech, at times nursing, and making sure that the goals our patients are working for, we are as well. And maybe we're just doing it in a slightly different way. So therapeutic recreation at Craig has a very long history. It is kind of the history of therapeutic recreation. So for more than 40 years, it's been an integral part of our therapy program here.
We're going to load the wraps right when we get down there, and we'll get you guys all and down to the boats.
One of the biggest pieces that therapeutic recreation is able to provide here at Craig is outings. We do outings with our patients almost 7 days a week. At the time our patients are here, up to the part where therapeutic recreation is involved with them, feeling a lot of loss. There's many things that they feel they won't be able to do, or at least the sense that I won't be able to do that. Things have been taken away. When therapeutic recreation gets involved, we can finally give something back. And there's many things that we and our patients and their families learn are possible.
Because I didn't do it before, I was paralyzed, and so I'm going to do it now.
What we are able to do now is transfer patients instead of say, here's what you can do. What we say to them is what you want.
When you're at your lowest point, you don't think anything's possible.
Very rarely nowadays is there something that we can't do. And that really makes it meaningful for the patient.
Expanded my horizons to what I was able to do at Craig and after Craig. Pretty important. It's really nice to kind of do something that I did and I'm comfortable doing.
Our patients aren't going to live at Craig forever. And what we really want them to do as soon as possible is to start practicing these skills in the real world outside of the beautiful walls that we have here at Craig. And so the outings really provide that opportunity. It's a chance to go, maybe have a little fun at the same time, either at a sporting event or a museum or something. But what our goal really is when they're on those is to be practicing those skills. It's a chance to really go out there and take all of those pieces and put them together. Sometimes the outings can be, a carrot and a reason to work hard. It's a motivator to go out and try some of those things. But our team understands there's more to it than the activity. The activity is not the goal. The activity or the outing is just a modality. It's just a piece that gets us to, accomplish and get them further down their treatment goals.
Cartwheel dismount.
Therapeutic recreation gives them, really addresses what kind of defines them. Those, I was an athlete. I was an artist, I was a musician, and we get to take that I was and make it an I am, and really either re-engage them back in things that they were actively involved in prior, showing them that it's possible again, either with adaptive equipment or modifying the activity.
This is awesome. You can kick back. Like I said, I can't get up and do things, so you can sit here and work on it and put your time and effort into it and see it done. See it appreciated, you know what I mean?
No different from the rest of Craig, the therapeutic recreation department really we want to lead. We want to be setting the standard for therapeutic recreation. Therapeutic recreation specialists, or CTRSs, which is what we employ here as staff here at our therapeutic recreation department, are on every doctor's team. They are very much integrated with the goals and care that our patients have from the first day they're here, and sometimes well past when they leave our facility. And at Craig, all of our staff who work in TREC or therapeutic recreation department are CTRSs, or certified therapeutic recreation specialists. Our role with our patients in therapeutic recreation doesn't end when they discharge. We have programs, our staff follow up with our patients when they get home to make sure that those resources and tools that we've given them on an inpatient basis that they're continuing with, because it is really a key to wellness and success on discharge. So they follow up and make sure those community connections are being made. We always want to kind of pushing the edge of both outings on the inpatient side and really making sure we're providing the best therapy, and making sure that what we do when patients go home and do the adventure program is also something that's not only fun, but really is, it really is therapy. It really is valuable. It really is helping our folks have a quality outcome and a great quality of life. And that's our goal.
All right, there was a couple things that I took from that several things I really liked on that. You want to take the patients from I was to I am. I love that statement. Never really used it before, but it's, that says a lot if you think about it. Did you see the kind of things they were doing in that video? Do you think those people thought that they were going to be doing those things? I mean, do you think the girl in the wheelchair thought she would be going sailing anytime soon? Or skiing or the rafting? I mean, they had some really, really cool things. I'll tell you something else about this place. I don't know anything about that facility. Might want to look into it, because it might be a really, 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 really fun place for somebody to go do a CTRS internship if you needed to do one, because apparently they have one heck of a budget, because they were doing some hardcore stuff. I've never worked anywhere that had a budget that would allow me to do scuba stuff and go on all these. That was some adventure stuff they were doing. It's either privatized and funded by, families and that's how it happens, or it is a really, really well funded, public facility. I would say it's a privatized setting for sure. Really, really cool looking place though, and they did a lot of extraordinary things. All right, let's look at what I handed you. And just for the ones of you who aren't here, what we're talking about, and it's not clear here, but we're doing a bingo sheet. And we're fixing to get here's the rules. Let's run this activity like this, kind of like we're going to do it. Today we're going to do people bingo. I'll give you an opportunity to interact with each other a little bit. And there's some things that I need you to remember. We are still under COVID protocols, so what I need you guys to do is to not breach those rules that we're supposed to do. I don't need anybody to take off their mask. I don't need you to get any closer to each other than you are. Matter of fact, you can stand up where you are to do this, but what you need to do is see how fast. I want everybody to find a bingo, okay? You need to find somebody in here who is left-handed. Pick your bingo row or rows, but you might, it should get loud. And I need you to find somebody and be for real. Don't just mark. And I know you're not going. Y'all don't know everybody's names right now, but get initials. Just get them to yell out your initials. Say, hey, I need somebody left-handed. And if you're left-handed, they say, okay, what's your initial? Put that on there. Put it in the box. Okay? So we're going to.
Can you be more than one?
Listen. You can be. Don't start yet. Stop it, Peter. You can be more than one person on somebody else's. I mean, there might be one left-handed person in this room. If y'all figure that out, do it. But just try to get it done as quick as you can. And let's start now. Don't break COVID protocol. I'll give you guys a copy. I'll have more copies when you come back to class. I'll be glad to give you a copy of this. It's just a little fun activity where they have to find people who may be left-handed, someone who loves horses or dolphins, does not drink soda, has kept a New Year's resolution, hates spiders, things like that. So just think about it. Kind of fun. We got a bingo yet? Anybody got a bingo? You got a bingo? That's what I'm talking about. For you guys that are not here, no class Thursday. No class Thursday.